go.
Hello, everyone. I am Tim Mack, and welcome to ASCII Anything. I will be your host today. Healthcare data is complex. John Murphy makes it actionable. John is one of Moser Consulting's foremost experts in healthcare data modeling, interoperability, and governance. He has decades of experience spanning healthcare, insurance, and financial services. John brings a rare business first perspective to complex data challenges, and he played a pivotal role in developing IBM's Unified Data Model for Healthcare, UDMH. I don't know if everyone knows what that is, but that is IBM's standard for healthcare data used around the world, and we are fortunate to have him working here with us today. He's also led large scale healthcare data integration initiatives for organizations ranging from small providers to national systems with thousands of hospitals and hundreds of thousands of employees. John's expertise spans FHIR and HL7 standards, data governance, privacy and consent, legacy system modernization, and large scale data transformation. What sets him apart is his ability to translate highly technical standards into real, measurable outcomes, helping organizations improve compliance, integration speed, data quality, and decision making. I am the director of data here at Moser Consulting with 20 plus years at Moser. Today's topic is healthcare data interoperability, including FHIR, UDMH, and compliance. We're going to connect clinical, claims, and operational data safely with FHIR and IBM's unified data model for healthcare. And we'll unpack how the better models and governance enable population, health, quality reporting, and analytics that matter. Without further ado, let me introduce John Murphy.
Good afternoon. My name is John Murphy. I am a 20-year employee or have a relationship with Moser. I've been in the data governance, interoperability, data conversion space for 30-ish years in the insurance and healthcare practices. I have been an employee of IBM and a consultant with IBM in developing and deploying some of their healthcare assets. I was on the primary and initial data modeling team that created the UDMH product. I will spend the rest of this conversation talking about how the FHIR standards and things like the healthcare standards interact with data components and how they both enable the data governance within the healthcare space. I have prepared a PowerPoint, and there are questions that Tim will work through to drive this conversation.
Well, I can start with a real softball for you first, John.
Yes.
What are practical steps to map legacy data into a modern model? Because we all know what our hospital systems were, and they're slowly getting electronic health records. So how are you going to help people figure out what to do with that legacy data and bring it into something modern?
So that ultimately, when we tell stories and data, we tell people what we're going to tell them, and then we tell them the story, then we told them what we just told them. You asked the question about what I'm going to tell you, right? And so that's in the middle of the conversation. Healthcare, one of the advantages of dealing with healthcare data is everything has a standard to it. Because of privacy and regulatory reporting and just the financial risks and the like in healthcare and the outcomes and the need for good efficacy of care, the data in healthcare is central to everything. And it's sensitive and it's important and it's valuable, right? So mapping practical ways of mapping data exploits all of the things that we'll talk about, like FHIR and some of its precursor products like HL7 and other industry standards that describe in universally accepted dialects the data that's being presented and created in healthcare, right? So there's a lot of data. I will show you the data model that we created at UDMH, and it's a big model. One of our models, where there's three of them, the business model, has something like 20,000 entities in it, right? And 60,000 data elements. It's a big model. It's a complicated model. It's a relational model. Practical answers to how to, help map this data is start with a chunk of it. You aren't tomorrow going to create a data mapping to 60,000 entities. It's not a thing, right? So pick a scope, and I get into that. There's a question at the end on how the roadmap works, and I start with that assumption. Pick a piece of it and what you want to focus on. And then it's just data mapping. You guys know what a patient is. You guys know what an encounter is and a clinical order and a drug code, right? That's the data we're talking about. So when you pick the scope of data that you want to analyze, report on, prove that you're compliant to some sort of regulation, that's where you start.
I was going to say, John, I had some experience with the Centers for Medicaid and Medicare. And one of the things that happened while I was doing that, we went from ICD-9 to ICD-10, and all those codes and everything changed.
We are of the same vintage, yes. We
Yep.
dealt with two diagnosis code schemes at parallel for we were supposed to do it for like 18 months. We ended up doing it for 10 years. Yeah. And so we had to understand ICD-9 is the International Classification of Diagnosis. Right. So they went from version 9 to version 10. And there are something like 40,000 diagnoses that are accepted that drive healthcare activity in ICD-9. There's something like 60,000 of them in ICD-10. And CMS, the Centers for Medicare and Medicaid Services, force you to report your claims, recording the diagnoses that were done on the patient to drive the services that you're being compensated for. So the diagnosis scheme is half the story of all of the claims generated in the United States, a couple $1 trillion business we do in the United States. Not a trivial deal, right? So the saving grace to that complexity and that chaos was they're both standards. Everybody studied, knew, memorized. ICD-9, it was out there for 20 years or so. And they did the same thing for ICD-10. They understood the two things. The challenge was managing both of those schemes at the same time in our systems. If it wasn't standard, if it wasn't universally accepted, it just doesn't work. And that's an advantage in healthcare. It's a complicated world. You'll see how relational the model is. It's a complex world, but everything has a standard that you can refer to give you some context. And that's where FHIR comes into this conversation. So when we start into the PowerPoint, I'll describe what FHIR is and its cousin HL7 and how we use them in healthcare and how we use them in the data governance of healthcare. And that's the story that we're going to traverse today.
So, quick question. Where does FHIR make integration measurably easier compared to, you mentioned HL7? Is there an easy way to make that comparison before we jump into your presentation?
Well, so let's jump into the presentation. That's where it starts. That's where my
Okay.
presentation starts. You kind of have to understand what FHIR and HL7 are before you understand how they help interoperability. And I'll tell you what I'm going to tell you, then I'll tell you the story, then I'll tell you what I'm going to tell you. The story I'm going to tell you is FHIR is the enabler of interoperability. It's what it does. It's a messaging system that will describe standard healthcare transactions with standardized presentations of the data. So
Okay, John, real
again,
quick before we get started,
yep.
I want to mention to our listeners because we have a video version of our podcast that is on YouTube, and if you're downloading the audio only version of it, please go to the episode page, and I will have the slides that he is referencing attached to the episode as image files so that you can reference the images that we're referencing. We'll try to describe them as we're going through them, but they will be available as a resource on the episode page wherever you get your audio podcasts.
All right, so quick introductions again, senior data consultant in the data governance practice at Moser. Data governance is what I do. And Tim wonders why I work for them, because they let me subcontract with the people that do this at the international level, right? And I work with Moser clients, I work with IBM clients, I work with state clients, national clients. So Tim will drive the conversation. This presentation just gives a visual emphasis to the pieces that we're going to talk about. And I'm going to start with FHIR, right? What is FHIR, right? It is the primary health interoperability standard known in the healthcare industry today. And as I mentioned before, the advantage of healthcare data is that it is so important and so expensive and so universal and complex that people were getting lost in the complexity of managing this across systems and hospital locations and the like. So the universe started in the United States. It is a universal standard in the Western world, essentially, with healthcare data systems, is that if they're going to talk to each other, they're going to talk in some dialect of FHIR or HL7, right? It is absolutely universal. It's a huge advantage in the healthcare space to have those sorts of common workspaces to exploit, right? So FHIR is the big one. It's the most recent one. It's the Fast Healthcare Interoperability Resource. There's your word for you, right? It's right in the name of the thing, right? Interoperability. When my admin system, EHR system, needs to talk to my pharmacy system, it's going to send a pharmacy request. Oddly enough, there's a FHIR message that is a pharmacy request. If I have a clinical order, I want to know, you see all your hospital shows, I want a Chem 7, CBC, et cetera. Those are clinical orders for chemistry tests, right? There are messages for ordering, and there's messages for the results, right? The imaging results, clinical test results. All of those are defined in the FHIR standard, right? So what is FHIR? It's a message-based system to move data across between systems. And every system that is commercially available will talk to FHIR, and it will ingest FHIR messages. It's developed by HL7, which is a Health Level 7 consortium. It's international now. It started in the United States. Europe and Asia, most of it, I don't know about China, but I've worked with HL7 and the like in Asian projects. And the United States, big in the United States, will talk in terms of FHIR. What is it? It's a message. And what the message does is it organizes a set of resources to describe some healthcare transaction. The one we always start with is called admit, discharge, and transfer, ADT set of messages. So when you admit a patient, there's a message for that. When you discharge a patient, there's a message for that. When you transfer a patient from ICU to a bed, that's an ADT transfer message. There's a message for that in FHIR, right? When I have a person in a bed and I want to see if their urine output is improving, or any presence of a drug, presence of a pathogen, there's a clinical order for that FHIR message. And when you get back the glucose level for somebody, message for that. It's the lingua franca of healthcare. That means everybody knows how to talk to this dialect. And if you want to know how, I will tell you the ultimate punchline to this entire story is if you want to know how this improves interoperability, it defines interoperability, right? It's universal, it's consistent, it is the thing that healthcare resources do.
So John, I was
yes.
going to say, in our healthcare system today, I see FHIR being a big thing, especially now that as we go visit any medical facility, we all get transferred to a specialist to look at that one thing. Do you see that the way that FHIR has matured over time, that process of going to a cardiologist or going to endocrinologist and that data being transferred and following you around with your electronic health record, has it gotten better? Is there more things they're tracking and that's why it got better? Or is it more about the standard so everyone's communicating better?
It enables all of that, right? Because there's a standard, it will get more predictable. One of the pieces of chaos that we had in all of this is System X had a EHR record in this format. Somebody else had an EHR record in that format. And to tell you the truth, what FHIR liberates you from is not caring what that specific system stores their EHR as. If my system needs to send an EHR to your system, it will send all of the requisite procedure messages and admission record messages and finding messages, all of that to the system, and that will present to your EHR how that system needs to present the EHR. They're all doing the same thing, slightly different file formats. Doesn't matter anymore because FHIR, if extracting data into FHIR, ingesting data from FHIR is known to your system. You will present a recognizable EHR at either end of that conversation. So EHR mapping and Epic. Epic is one of the primary clinical systems in the world these days. There's two major ones, Epic and Cerner Oracle, right? Epic EHR data maps to HL7 standards, and HL7 is FHIR and HL7. We'll get into HL7 in a second. It will send HL7 or FHIR messages however you need. It'll do both, right? Does it do FHIR? Does it do HL7? It does both, right? It sends an A01 message for an admission, ORC message for a common order. I think that might be a segment. It'll send that message, and it will know how to ingest that message. That Epic. Oracle Cerner is the other one. Q Oracle EHR mapping components. Apps to HL7, right? Facets. Facets is a claim system. You wouldn't think it necessarily had to know clinical data. Well, there's a lot of clinical data that payers want to know. Facets, a claim system maps to HL7, right? And we'll get into that, another standard that these claim systems deal with. But those are the three big systems that cover, it's got to be 90+% of the data created in our primary healthcare providers in the United States. Cerner and Epic are the market. And Facets just plainly is the market for payers. Everybody that's doing serious work in payment for claims is using facets. Any important healthcare system in the United States, Western world, Epic and Cerner facets, or even NHS uses facets for their payment systems, right? Talk to FHIR and HL7. It is universal. So what is FHIR, right? It's the transactional data that is recorded by EHR systems and the financial data that it generates because of that activity. The content, and that's all I'm going to worry about today with FHIR is content. The level 1 and level 2 here are important on implementing FHIR. But what FHIR does for you is this level 3 and 4. It manages and tracks the data used in administration in healthcare. Patients, practitioners, care team, devices, locations, the hospitals, the beds, whatever. It has a series of terminology built into that, which is then used when you are describing the clinical and the diagnostic and the medication workflow and financial pieces of healthcare delivery. It tracks procedures and allergies and problems and encounters, the medications ordered, the medications distributed, right? Because there's a difference, right? That's what drug systems are doing for you. Observations, the request for observation, the result of the observation, the specimens I've taken, the management of specimens. All of that can be represented in the data in the various FHIR messages, right? And I won't get into what messages there are here, but there are things like ADT and orders and findings and imaging services requested, et cetera. Drugs ordered, dispensed. Level 4 really is the heart and soul of what FHIR tells you. The rest of it's how it tells you that. And the context of patient, practitioner, care team, et cetera, is the context that you're doing all this with. It's the master data management. We'll get into this administration concept, the data in this administration concept later as we talk about the governance of these projects and things you need to do to make your interoperability projects work. I will talk about HL7 too. It's actually the precursor to FHIR. Again, FHIR is defined by the HL7 consortium. HL7 is just a message-based system that is text-based. And if I show you screenshots of these things, it will be in HL7 because the text-based definitions are a lot easier to look at than the JSON definitions are. JSON's not all that human-friendly. Systems love JSON. You're going to implement FHIR. But if you're doing these interoperability projects, HL7, my ratios are probably dated. When we did the UDMH model in 2011, HL7 represented about 90% of the interoperability capabilities within the healthcare systems. About 90% of the new projects were in FHIR. And so I'm assuming that ratio just flipped pretty hard. But HL7 is also an incorporated, accepted, supported structure in these various health systems. We saw Cerner, we saw Epic, we saw Facets all dealt with both HL7 and FHIR. So I just threw this term out to contrast what traditional lingua franca was for healthcare versus what you're going to see in new projects, right? The terminology they use in HL7 is we have messages that are comprised of segments. Patients a segment, encounters a segment, the orders, the findings, et cetera. Those are segments that create a message. And all the segments contain elements. So it's an interesting modeling structure. And at the risk of having a busy screen describing this stuff, HL7 is described by 17 chapters of messages. About 13 or 14 of them are actually messages. 2 or 3 or 4 or 5 of the chapters are overhead definitions, segment definitions and catalogs and the things like that, and how to deal with codes and those sorts of things. But this is what a message definition looks like. This is not actually a message. This is how we look at the message definition. And this is an A01 admission record. And what I will do is expand on that right side of this, right? So what a message has is a header and an event type. So A01, this segment defines it as an A01 message. The PID and the PB1 segments are the patient and the encounter, patient visit, right? All messages in HL7 and all messages in FHIR will include a patient and an encounter. All of the stuff we do, well, I should say all the clinical, all the EHR level stuff, transactions that we do in healthcare, will be in the context of a patient, in the context of a visit. That's the nature. So people ask me over the years, is the UDMH, HL7, or whatever, patient-based, member-based, or what? HL7 and FHIR are visit-based. You do things within the interaction with a healthcare provider. That's a visit. And so we always have a PID, PV1 record to describe what patient it is and what's the visit we're dealing with. Inpatient stay, outpatient stay, phone visit, whatever. The rest of these things are what we know about the patient and their environment as we are admitting them. We know what their observations are. The Chem 7 says they have this condition, admit them. Right? So we know what their admitting conditions are, the diagnoses. A diagnosis, we know what the admitting set of diagnosis was. One of the quality, you ask about outcomes, one of the quality analytics will be, did we do the services for that visit that were really in the context of the diagnosis set that we had for that patient? Do we readmit this person within a certain time period for the same diagnosis, i.e. we're not treating this person? Readmission analysis is a quality metric in healthcare. If we're seeing the same diagnosis for frequent admissions, we're not managing this patient's outcome correctly. The other thing I will point out later on, I'll emphasize this later on, if you're thinking in terms of the data relationships here, this is a relational presentation of healthcare data. I built a data model from this. I built a relational data model from this. This is the relational representation of data. We know that a patient's related to a visit. The visit, I don't have the PV1 segment up here. I do have the PID segment. The visit itself, that segment described an admitting physician, attending physician, a primary physician, et cetera, right? That's a relationship between the visit and a series of doctors or other healthcare professionals that were interacting with this patient. That's a piece of relational data. And we'll see what that looks like in a data model here shortly. But HL7 and FHIR by extension is also a kind of a nested relational representation. So this is the patient identification segment. It describes the patient's demographic data. It's got an ID on it. It's got a date and time of birth, their administrative sex, their race. And it's got an interesting column that says repeat, on the number of times it repeats. In a data model, if a piece of data repeats, the only way to represent that in a data model is to have a normalized table. So in this model, we will have a race table attached to the patient. We will have a series of phone numbers. So we have a phone number table. We have a name table. Notice that repeats. So this thing is describing a series of relationships between a patient and a visit and an admission, right? So there's two things that made this very useful as a structure, a standardized structure for defining a data model. One is it is universal. Everybody will talk about or be able to talk about EHR data in this context. So if you make your data model look like that, any transaction you create from this kind of data or data that can be supported by this standard can be put into an equivalent data model. And not to predict the conversation about UDMH, but that's exactly our design approach to UDMH. So the last thing about this, I get that, is they've got a name. Well, it turns out the data element itself is a piece of relational data, right? So the patient name is contained of a series of data elements that describes extended party name or patient name. I think it's actually extended patient name, family name, last name, first name, et cetera, right? So we know what the content of a name table would be. We have to support the family name. We have to support a given name. We have to support initials and all of the data elements within this model, right? Within this data representation in our data model to support this standard. It sounds easy, and it wasn't necessarily easy, but it was consistent. We were able then to mechanically do the same thing across all 17 chapters of HL7 to create the data model. And if you notice, I didn't point this out earlier, but when you see this presentation, you will notice a URL at the bottom. If you want to learn about FHIR and HL7, there is a certification. I was certified, and I'm not sure if I still am. I have to go back and check my expiration date, but there are certifications for these things. And if you get tired of writing JSON interfaces or this, you can make good money being an HL7 expert data analyst in healthcare spaces, right? So there is a lot of knowledge to be had at various levels. You can attack this as a business person, as a clinical person. as a JSON ETL developer, as a messaging broker, as a whatever, as a security person, right? If you need to deal with the security of healthcare data, FHIR and HL7 have pieces that will either store or enable that piece of the data governance of this data. These are profound standards, right? And they've been universally accepted. It's a very powerful asset in the healthcare space. What are the implications of having these standards? Well, we made a good data model out of it, and the IBM sold it for 15 years, right? It is an excellent standard structure for things like MQ message hubs, as you might imagine. And it's one leg of the migration mapping tripod. You asked earlier how some of this stuff enables mapping. Well, if I have a UDMH model or a data model I built myself, and I have Epic, and I need to pull the clinical findings out of Epic, and I don't really know the implication of my data model, but I've mapped my data model to HL7, and Epic has a mapping to HL7. I can compare those two mappings. It will answer the questions, what do I do with this finding unit? Does it have to be in fractions? Does it have to be a whole number? Does it have to be whatever? Right. However, HL7 and Epic talk to each other, and however you have agreed to allow your data model and HL7 talk to each other. If you can't figure out the mapping from Epic to your data model, you have an arbiter. Right. So it's the first leg of what I call the Rosetta Stone capability of this standard. And I would use any of the standards in healthcare that way. The relationships to database content and application content make excellent inputs to data governance. And we'll get into this very hard soon, but the beginning requirement for data governance is a data catalog. This is a marvelous data catalog. HL7, FHIR, 837 for claims, RX1 for drug codes, LOINC for clinical order codes. Pick one. They are good context for terminology within a data governance catalog. And as I pointed out, HL7 and FHIR explicitly encounter a patient. They're transactional, right? Something happened in the context of a visit, interaction with a healthcare provider, which is an encounter. FHIR, HL7, and 837, I've talked about 837 a little bit. They define a relational representation of healthcare activity. 837, and I won't get into that here, it wasn't the question at hand, but it is the equivalent to FHIR in the payment world. CMS forces you to submit 837 compliant claims to be compensated. And if there's any incentive for healthcare providers to have good data quality, it's that if they don't give you a good formatted data presented in the code system that 837 and CMS demand, you are not going to get paid. That's an incentive. So 837 is the lingua franca of the claim system. So it's an equivalent thing. And so if you're working with payers, there's good documentation on 837, 834, and 835, which is the signing up of members in not particular order. One of them is for signing up members to a health plan. The other is to claim for healthcare services, and the other one's the payment for healthcare services. As you might imagine, all three of those are fairly important to payers. I don't use the term X12. 837, 834, and 835 are all part of this thing called an X12 standard that is recognized by the International Standards Organization as a standard electronic messaging format. Now, 837 in claims, it is in chapter 8. There are something like 12 or 13 chapters, and it's the 37th message defined in this 800 series. So there's thousands of messages from moving freight on ships across the sea to submitting healthcare claims, right? So that is an internationally established standard for submission of claims. Definitionally enables an interoperability, right? And so healthcare is lucky, smart to have all of these standards. The chaos otherwise would be unmanageable.
I say, and John, you gave a good example there about use cases of tangible patient and provider outcome of, hey, this person keeps on coming back for the same thing. We can see that here in our data. And then I think you gave another good example of, hey, if you're using these standards, you're going to get paid by the insurance company or the person because you're processing claims in a manner that everyone can see and talk about and translate and get everything moving forward. So lots of abilities of using these standards to help on both the payment side and the patient side.
Right. And so 837 is a beautiful example. I will emphasize it later on. We talk about the data governance pieces of this. And one of the primary pieces of data governance that you have to deal with, just the volume of the data requires that you do it, is reference data management, right? All of the coding things you do to submit a claim. What's my discharge disposition? What's my payment status? CMS has a defined set of values you have to use for that. And that's a specific set of data. In this model, and we'll talk about the UDMH model here and how we used it, our business model had about 60,000 data elements in it. And there are some technical elements in this stuff, but about 20,000 of those elements were some sort of enumerated code. A claim status, a drug code, a procedure code. 20,000 out of 60,000 of these things were some sort of enumerated value. That volume will crush you if you don't have a way of automatically dealing with reference data. It defines a requirement for these interoperability projects. So let's talk about UDMH. What is it? It's a data model we created with a third party, and they were a group purchasing organization that was collecting clinical data for the people they were purchasing for. There were 200 or 300 small hospitals across the country. And so they were collecting data so they could do large volume analytics on their data that these relatively small hospitals might not be able to do individually. That's where we came in, with the clinical side. What they brought to the table was they were the supply chain experts, right? So this is a unified data model for healthcare. It has clinical data, it has surgery data, it has claims data, it has supply chain management data, and it has a rich, relatively straightforward ability to manage reference data. And again, it is a base requirement for any data store in healthcare to have the ability to deal with codes, simple codes or complex codes. Now, it's an obsolete suite of tools. Now, why am I talking to and introducing a product that IBM no longer sells? We'll get to that later on. There's two things I will want you to take out of this conversation. One is UDMH represented a very strong process for developing a data model, right? So if you need a warehouse model, a core warehouse model, or some sort of analytical structure for your healthcare data for analytics, the approach we took to UDMH is absolutely repeatable. You go out to HL7, you see a message that says, I admit a patient. Oh, by the way, this patient is related to this visit. This visit contains all these doctors. That's a relational model. And so take that structure and that process that we took for UDMH and repeat it however you need to repeat it. The second part, and I mentioned this at the end, is the content of UDMH. There is data content in here, and there's analytical content in this model, was extracted from the model and put into IBM's. Then they have a whole suite of these things. You would think they have one tool that you buy for healthcare data governance, but there's a whole set of tools that this content forms the basis of the catalog for the other things they do for like PII management, the security management, the data quality management. This data content formed the genesis of that data catalog. So UDMH is still relevant, even though it's not a data model that you can purchase anymore. So let me describe how we went through this, what it is and what it looks like, and how we went through this and what it does for you then. It was created by IBM with explicit permission of HL7, ISO, and other standard organizations. The beautiful thing about subcontracting with IBM on this is they're on the board of directors for all these consortiums. They belong to HL7. They're on the board of HL7. They belong to the international standards organizations. They subscribe to ISO, and by the way, that's for the 837 stuff, right? So not only did we have permission to use the metadata for these various standards in our modeling, we own the metadata for that standard. And so if you're looking at the patient, there's a gender. It's highly likely we use the HL7 definition for that gender, for their discharge status, for their whatever, right? So it is very much tracking to the standard that applies to that piece of the model. And as I said, mechanically earlier, I described it's not the most complicated process in the world. 17 chapters worth of it. It's a lot of it, and you have to keep it all straight and you have to be consistent. But that really, really enabled a profound data model to be derived from this. It's a set of data warehouse models, right, where history is emphasized. We have an atomic model, which is used to create core warehouses. It very much tracks Dan Lindstedt's data vault methodology. And if you went straight Dan Lindstedt data vault methodology, you could use that model to accelerate your effort. That's a standard. I don't have any intellectual property rights to any of his images, so I don't include any of them. But if you want to do data vault, turn the patient into a hub and satellite pair, create an encounter as a hub and satellite pair, create the relationship defined by the ADT messages, as a relationship between the patient hub and the encounter satellite. Very mechanical, and just work that through to the scope of your project. And again, as I said before, UDMH, FHIR and HL7 and 837 and some other standards form the basis of the catalog within the data governance tooling offered by IBM. They have accelerators. They call them knowledge accelerators for an industry. They have insurance and telecom and manufacturing, financial services, banking. I happen to be involved in insurance and healthcare. Those are my two industry models I dealt with. They have a knowledge accelerator that includes this content, both from a base concept standpoint, a relational concept, this term relates to that term, and the analytical content. So they take the HEDIS requirement, describe it in their data governance catalog, and the related terms show you how to take one of the measures that HEDIS wants and to create that measure, right? So that's the value proposition of something like HL7, UDMH, and these other standards is they make a common recognizable set of data content in this governance tooling. I did have one client that was taking the UDMH content and trying to put it in Purview. Theoretically, that's possible, and you would have all the same kinds of capabilities then in Purview. I tried really hard not to make this sound like an IBM commercial. I have worked with IBM for 25 years, and so I like these products. I'm familiar with these products, but I understand there's a wider world out there. And so this approach to governance catalogs and to modeling and the like is repeatable, is extensible, is something you can do in other tooling. It just happens to be in this tooling, right? So if I was to recommend anything out of this, take a look at it and see what you think about that sort of approach to the data governance pieces in healthcare.
Thanks for tuning in to this week's episode of ASCII Anything, brought to you by Moser Consulting. We hope you enjoyed listening to part one of our three-part series on healthcare data modeling, interoperability, and governance with John Murphy. Be sure to join us next time as we dive even deeper with John into the world of healthcare data. Don't forget to share your ideas or topics with us on social media. In the meantime, please remember to give us a rating and subscribe to our feed wherever you get your podcasts. Until then, so long, everybody.
Go.